The second one is that doctors are very used to charging patients for experimental therapies. Even though we think it's unethical here, the practice there is that this is usual practice, and patients expect to pay for experimental therapies. The third is that now the regulatory environment is perhaps the strictest in the world, in China. And the fourth one is that there's still not yet a definition of the fields of orthopedic and neurosurgery, so there's a fuzziness in the field, and let me just discuss these in some detail. So, as many of, well, almost very few people nowadays remember the time before clinical trials. But I went to medical school in the 1970s before there was real clinical trials. And in fact, the NASCA study, the National Acute Spinal Cord Injury Study, was the first randomized spinal cord injury clinical trial, and that occurred in the 1980s. In those days, we were taught, there wasn't evidence-based medicine. We were taught the art of medicine. And at that time, we were expected as doctors to give the best therapies possible to a patient and keep giving them until the patient recovers. I mean, that's the way medicine was being carried out. And if you try some experimental therapies, that was okay, because especially if the condition is really desperate, you as the doctor would take experimental therapies and give it to them. And patients oftentimes would pay for this, and doctors oftentimes would charge for this. And this is exactly what happened when the first heart transplants occurred. The first kidney transplants were that way. There weren't formal clinical trials, and the patients paid and the doctors charged. Of course, today, these things would be very hard to do because we would have to have double-blind randomized clinical trials. But in fact, almost all surgical therapies have not gone through rigorous clinical trials in the United States. And so, really, evidence-based therapies came about in the 1970s, and one of the reasons that they came about was a very interesting one that nobody has to date mentioned, and that is clinical trials are the only way you can disprove ineffective therapies. There's no other way. We haven't talked about clinical trials as a means of saying this doesn't work and therefore we don't use it. But this is one of the most important functions of clinical trials. And so, in the United States, there's now the culture of evidence-based medicine where evidence of efficacy is required for treatment approval, clinical trials are being used to rule out ineffective therapies, and safety and rationale only needed for trial approval. So this is something that Naomi mentioned, and I told her I'm so glad she did. In the United States, you don't need efficacy in order to go to clinical trial, to get a therapy approved for clinical trial, because one of the purposes of clinical trials is to show that it doesn't work. So a lot of people don't understand that actually China in 2004 imposed the highest standard of clinical trials in the world, much higher than in the US. In 2004, they imposed the highest international good clinical practices standard on all clinical trials in China. This means that all clinical trials must have all the paraphernalia of clinical trials, including IRBs, ethical reviews. There must be a separate room inside every hospital, patient confidentiality, and record-keeping practices. Everything must be according to the GCP guidelines. And they went one further. They require something in China that's not currently required in the U.S. or Europe, and that is they require clinical trial insurance coverage of all patients that undergo clinical trials. And they gave all the centers 2 years to get on board. And then 2007, they started enforcing. So currently, all hospitals are not allowed to do clinical trials unless they're certified both at the hospital level and at the departmental level. And at the departmental level, the head of the department must take an exam and pass it. It's actually very difficult. Many of the heads of our department really didn't pass it and had to take it over again. And so this is at a level is unheard of. Nobody asks the head of neurosurgery at Mass General to take an exam so that they can do a clinical trial, but they are requiring this in China. They also have a couple of other things that people don't know. For example, I talked to Jaren recently, and they were saying, well, what about, can we do a phase 1 trial in China? immediately I told them that, in 2004 they actually passed a law that says no overseas therapies can be tested in China unless phase 1 trials have been tested already. And that is because in China they're very concerned that the Chinese people are not used as guinea pigs for unethical treatments overseas. And then finally, in last year, boy, this is, we were talking with the SFDA, the state FDA of China, and all of a sudden the top leadership of all the SFDA disappeared on us. They weren't responding, so we asked for a meeting with them. And just before we went to the meeting, what we were told was the guy's been arrested, and oh, by the way, he's been tried, and they've sentenced him to death. And that when we arrived there, they already shot him in the head with a bullet. I can tell you this put a chill into the bureaucratic environment of China like nobody could imagine. And we have this wonderful woman who's a lady who helps us raise the money. She's head of our fundraising campaign. She's a very traditional Hong Kong woman, Hong Kong Tai, who whenever she goes to a meeting, she always takes out her capacious handbag and brings out these little gifts and tchotchkes for everybody. So she opens up her purse and she started giving to people, and all the people from the SFDA got up and ran from the room because they can't accept gifts. I mean, this is how incredibly tight the situation has become. So every rule, every I is dotted, every T is crossed. There are no exceptions. And they're very, very concerned, and they're extraordinarily cautious about approving anything that might reflect badly on them. Okay, and then finally, there has been, until maybe 4 or 5 years ago, there wasn't even a residency program in China. So if you want to be an orthopedic surgeon, you just joined an orthopedic department, you operated and operated and operated until they made you a member of the department. Then they call you an orthopedic surgeon. The same thing was true of neurosurgery. And orthopedic surgeons do everything. The peripheral nerve bridging I was talking to you about was all done by orthopedic surgeons. They have no hesitation opening up the spinal cord and injecting cells into the spinal cord. This is not allowed in the US. If we try to do this, we'd be shut down. Orthopedic surgeons in the United States work on only bone, and neurosurgeons touch anything below the dura. Now, it was very interesting how easy it was to get things going in China, because orthopedic surgeons could do everything for transplantation. But when we tried to do this in Taiwan, which follows the US standard, we couldn't get anything done. The neurosurgeons basically put their foot down and said, orthopedic department cannot transplant cells, absolutely cannot. And we spent 3 years getting clinical trial agreements signed. I think this problem will be present in the US, and it will be very significant. And it's very interesting, in China, 90% of spinal cord injury cases are taken care of by orthopedic surgeons. Neurosurgeons do not control this field. Okay, standards in China. I'm just going to point out the third thing, which is something that took us by surprise, and that is the military hospitals are our best clinical trial centers. It turns out that they're the first trials to be, first centers to be completely certified, and the order goes out, data is collected, treatments are done, and I can tell you, it's fantastic. The military system in China is very efficient and very good. Insurance. How do patients pay for their treatment? When I first went there in 1999, it was completely government-based. By 2004, actually by 2002, it had converted into this incredible mess. It was a cash-based system. If you didn't have cash, nobody would take care of you. 2004, 10% of the patients had health insurance, and then by 2006, 90% of patients now have clinical trial insurance, health insurance. But the strange thing, or not strange thing, the interesting thing is that it's 50% copay. So there is tremendous consumer pressure to keep the costs down. And typically what happens is that a diagnosis is made, doctor walks in and gives plan A, plan B, plan C. Plan A is cost no problem, best of treatments, all Western medicines, surgery, etc. Plan B is all generic, some surgery and some Chinese medicines. Plan